Good morning. My name is Kinga Budai. I am a hospital clinical pharmacist in the pediatric center, and my research field is about right antibiotic dosing in critically ill children. My supervisor is Csaba Lódi, and my scientific methodology supervisor is Mahmoud Obaid, my statistician is Silvia Kisdala. My vision is to improve the effectiveness of antimicrobial therapy and provide the best care for critically ill children. To accomplish my vision, my mission is to improve the antibiotic dosing based on scientific results and drug levels. So my two topics are connected to extended and continuous infusion of beta-lactams, and we compared this administration to the short-term infusion. The first topic is a meta-analysis. And about the background, the misuse of antibiotics is a real problem in medical world. It is a real concern that there is a rise of antibiotic resistance. And what concerns the beta-lactams, we have to maintain the plasma concentrations above the minimal inhibitory concentrations. And there are two options of delivery, the extended infusion and the short-term bolus infusion. And adult studies and meta-analysis showed that the extended infusion has benefits, and it was associated with significantly lower mortality. However, we don't know whether the extended infusion has the same effect in children. So our aim is to evaluate the clinical efficacy and safety of extended infusion of beta-lactams in children. We use the PICO framework to compare these two groups, the extended and the intermittent infusion, and our outcomes were clinical outcomes like mortality, therapeutic effectiveness, microbiological eradication, the length of stay, the drug levels, and pharmacokinetic targets. After the systematic search, first we included 35 articles in our data extraction, but after that, after exclusion of some studies, for example, there was overlapping population, only 25 articles were included in our systematic review and 19 in our meta-analysis. And I will show my most important results. First, the all-cause mortality, it is the hardest outcome of our study. We conducted a subgroup analysis. We distinguished RCTs and non-RCTs of observational studies. And the population was heterogeneous because they had different diseases, for example, meningitis, gram-negative bacteremia, or neonatal sepsis. We used the odds ratio to measure the effect, and if it is below 1, it means that the event is more common in the bolus group. And in this case, the odds ratio is 0.74. It is a statistically significant result, and it means that in the extended infusion group, there was a significantly lower mortality, and it has a huge clinical importance too. After that, we evaluated the infection-related mortality. We could include only 4 articles, so the population is very small. But so the odds ratio is 0.52, and it means that in the extended infusion group, less deaths occurred than in the bolus infusion group. And the population was small but homogeneous because every patient suffered from confined gram-negative bacteremia. However, further investigation is required. The microbiological eradication is also an objective tool of effectiveness. We included 4 articles. They published the microbiological eradication rate. So the population is small but homogeneous. Every patient was treated with meropenem, and the odds ratio is 3.18, and it means that in the extended infusion group, there is 3 times more higher chance to achieve the early microbiological eradication, and it can explain the lower mortality rate. And at least we assess the adverse events, we could distinguish two types of adverse events: the acute kidney injury and the hepatic adverse events. And those ratios are in year 1, and it means that the extended infusion is considered as safe as the short-term infusion. There was no difference. In summary, our strengths are the rigorous methodology, and it is a hot topic in a very vulnerable population. Our limitations are the limited number of trials. We included observational studies, and there was a heterogeneous population according to the comorbidities, ages, concomitant antibiotics, and we assessed the high risk of bias. In conclusion, the extended infusion is more effective in early microbiological eradication, and it is associated with a significantly lower mortality, and it is as safe as the short-term infusion. In practice, we can recommend the use of the extended infusion. However, further high-quality RCTs are required to decrease the limitations, and therapeutic drug monitoring is also necessary. And our manuscript is published in the Clinical Medicine journal. My second project is the same as our first project, but it is an RCT. So you already know the administration modes of beta-lactams, and we already know that higher probability of target attainment was observed in several pharmacokinetic studies with extended infusion in children, and our meta-analysis also has showed the benefits of extended infusion, but with limitation. And we would like to decrease these limitations and improve the quality of evidence. So we used the PICO framework to compare the two groups, and our outcomes will be clinical outcomes such as plasma concentration measurement and clinical efficacy and safety measurement. Briefly, we would like to include the pediatric patients admitted to PICU or NICU, so critically ill pediatric patients, and meropenem, piperacillin, tazobactam, cefepime, ceftazidime, ceftriaxone can be measured in the lab, so we will include these antibiotics, and and the patients will be included with confirmed or suspected infection. The suspected infection means that the signs and symptoms of infection is observed. The exclusion criteria are, for example, we would like to exclude patients with decreased renal function when a dosage adjustment is required, and patients with extracorporeal therapy or enrolled in other medication studies or with beta-lactam allergy. Our primary outcome is the proportion of patients achieving pharmacokinetic pharmacodynamic target. And so the beta-lactams are time-dependent antibiotics, and it means that the drug levels should be above the minimal inhibitory concentrations through the whole dosing interval. Our secondary outcomes will be another and higher target attainment and all-cause mortality, the adverse events, the microbiological eradication rates in different time points, the clinical success, the duration of antibiotic, and the length of stay. We are in an early phase. We are working on our detailed protocol. In summary, my two projects are connected to antibiotic dosing, and our aim is to improve the antibiotic dosage in critically ill children. And I would like to thank you for your attention with a quote: "Anyone whose goal is something higher must expect someday to suffer vertigo."
My main question is whether are there any adult data on this topic? So why immediately went to the pediatric population to check this question? What shows adult data, and is there any limitation to adapt to kids the adult data? So
Yes.
about continuous infusion and antibiotic, safety and efficacy of the continuous, the administration continuously the antibiotics.
So there are several adult data and RCTs, meta-analysis, and so the children have different pharmacokinetic properties.
But sorry, what shows other adult data? So it's superior to administer for adult patients.
So they show that the extended infusion is better. So,
okay, so
the same outcomes.
was it the expected result in your survey as well?
Yes.
Okay, great.
I would like to ask you a question about your first topic, so the meta-analysis. In your first forest plot, you showed that in the RCT group there was no statistical difference between the two types of drug modes, and the second. So only in the non-RCT group did you see a statistically significant difference. So in your combined result, that's the cause of seeing a a statistical difference. So could you investigate whether what the systemic difference is between the two groups, because that could basically tell you what the cause of the difference in significance is, right?
Thank you for your question. So, yes, this was an overall odds ratio, and it is difficult to say the difference. But, for example, in observational studies, so the population can be different, and they have different comorbidities, and the severity of the illness is different. So maybe this is the reason.
Okay, so it wasn't clear then what the difference was that basically changed the results.
Yes,
okay.
It was not clear, and concomitant antibiotics were administered too, and it can also cause difference.
Thank you.